Hello, everyone. This is Eddie Lang. I'm the department head for emergency in Calgary. And on behalf of CAPE, I am delighted to be your moderator and welcome you to today's webinar. I hope you're going to find it very useful and interesting. Just some introductory comments. Our webinar was independently conceived by our planning committee. That's Peter Heraklius, Kira Grewal, Bob Stremstrom, and myself. And disclosures for myself, note that any honoraria related to industry supported grants go directly to either the Calgary Health Foundation or the CAPE Advancement Fund for me. Next slide. So this is supported by an educational industry grant, and we will be mitigating all potential biases on the next slide through a number of important steps. Our planning committee was given the general topic, but we developed this, the actual specific content ourselves. We also have gone through complete accreditation with the Royal College of Physicians of Canada. We had the planning committee and CAPE's scientific group reviewing all of the content. Next slide. So just a little bit on today's webinar and where it came from. We're going to be meeting Dr. Adrienne Lee really soon. She's an awesome hematologist here in Calgary. She spoke to our group some years back on this topic, and it was an extremely well-received presentation. And we thought we should put it on again for a national audience. So this is all about unexplained bleeding. Now, of course, in emergency, most of what we're going to see is going to be related to anticoagulant therapy, but occasionally we will get very difficult bleeding cases, be it a prolonged epistaxis that's not making sense, or a huge hematoma that came out of nowhere that we need to investigate further. And sometimes the routine coagulopathy testing that we do is somewhat limited and doesn't always send us the right direction. So our key objectives for this session is that we're going to hope that by the end of it, you're going to be able to confidently recognize and initiate appropriate investigation. It's really a diagnostically focused webinar for unexplained bleeding abnormalities. You're going to manage these issues, whether it be around procedures or rare presentations. And there's a couple of new things on the block that we need you to be aware of that Dr. Lee is going to be talking about, because it is an area that could be potentially fraught with risk and poor patient outcomes. So next thing I want to do is tell you about how we're going to make this as interactive as possible. Some of you have already logged into the Menti details and have entered the code. We've got a few questions to help us get to know you better. And why don't you go ahead and see if you can log in and get the first questions off the ground so that we can know a little bit more about you. And I think we're going to hopefully show those results and then move on to the second question that gives us a sense of where your comfort levels are around the topic. So, while we're waiting for things to load up, I hope everybody is keeping well in these challenging times and staying safe, and that you are enjoying some of this warmer weather that I hear is hitting. Well, I know it's out here out west, but hopefully it's hitting your neck of the woods as well. All right, so looks like we have largely an urban practice setting, but a nice representation from rural. Thank you. Jeff, can we do the next question? And now it's about how comfortable you are managing bleeding episodes, and just waiting for your votes to come in on that. So we have just a couple of votes, a little bit of discomfort, a little bit of comfort, but it's a Goldilocks situation. We have most people in the middle, not liking it, not finding that it's too challenging, or, well, we do have more on the uncomfortable side. So nice to see that. Thank you for everyone. And now a bit more of a specific and technical question. It's about what do you do when, and we're going to talk about whether you routinely get these, but what do you do when you get an abnormal PTT? Do you know exactly how to work that up? Who needs referral? How high should make you uncomfortable? So we've got no one feeling very, very good about this yet, but just waiting for a few more votes to come in. And yeah, it looks like we don't have anyone who's lost, but of the 10 or so votes that we've seen come in so far, and please feel free to keep adding, most are uncomfortable. Are there additional tests that you need to order? Who do you speak to? Who do you need referral? And you will be in far better shape. We hope that by the end of this webinar, all of those uncomfortables, we're going to be going to comfortable or very comfortable. Okay, so it is my pleasure at this point to introduce Dr. Adrienne Lee. She's a clinical associate professor here in Calgary, Cummings School of Medicine. She works in the Division of Hematology and Hematological Malignancies. We've actually gotten a chance to work a lot together through the Alberta Rare Blood and Bleeding Disorders Comprehensive Program, where we have had a lot of work done on care plans and focused ways of treating patients when they come to the emergency department with bleeding complications. Dr. Lee, thank you so much for joining us and agreeing to speak with us today. I will let you take over the baton.
Thank you, Eddie, for that great introduction. I'm very happy to be here. I'm just going to share my screen. All right, thanks again. Hopefully you can all see this slide here. So I've been asked to give you some clinical pearls about more sort of rare bleeding disorders, unusual presentations, coagulation abnormalities that you might come across seeing patients in the emergency department, and give you a brief glimpse and sort of what's in the pipeline, what's new coming in hemophilia that might affect how you manage bleeding in the emergency department. So these are my disclosures. I have honoraria from Takeda as a part of an advisory board, but really nothing relevant to this talk. So I'll dive into the first case. So this is a 76-year-old gentleman with a history of paroxysmal atrial fibrillation. He shows up in the emergency department. He's known to be on aspirin and has a history of prostate cancer that was diagnosed in 2010. So he comes to the emergency department more than once. So I'll take you through this real case scenario. So on his first visit, he comes in with left calf pain. There's swelling, there's some bruising, and the emergency physician who sees him does an initial assessment and deems, okay, this could be a DVT or a ruptured Baker's cyst. So the patient goes on to have an ultrasound Doppler. There's no evidence of DVT, but there's a report by the radiologist of a complex collection, and they left a differential in their report as this could be a ruptured Baker's cyst, or a loculated abscess. The patient then gets sent home with instructions to return to ED if he has worsening symptoms. So 4 days later, he comes back to the emergency department with increasing calf pain and some presyncopal symptoms. So the patient goes on to have an ultrasound-guided aspiration, and surprisingly, he actually was aspirated for frank blood, and this was a complex hematoma. So first polling question for the audience. In your emergency department, what initial coagulation studies are typically ordered in a case such as this, especially in someone where you're maybe considering an invasive procedure? Okay, so we've got some answers coming in here. It seems like most would order both the INR and the PTT. So looking at both the intrinsic and extrinsic pathways. I know there are some centers or some movement towards doing INRs only when screening for possible bleeding. Looking for patients who might be on oral agents or anticoagulants, inadvertent ingestion of anticoagulants. Okay, so it looks like most people would order an INR and PTT. Okay, great. So I'll go back to my slides here. All right, so just gonna take you through some of the blood work that was done in this case. Oops, sorry, my screen here. So just a bit of history. So 4 years before he presented with the calf swelling, you have some historical data. So he had a normal hemoglobin at that point, a normal INR, and a normal PTT. At his first Emerg visit, when he first came in complaining of the calf swelling and pain, his hemoglobin was low at 92. His platelet count and INR were normal, but he did have a prolonged PTT. When he came back at his second visit, his hemoglobin had dropped down to 68. He did get a red cell transfusion at this point. And again, his PTT was prolonged to 96 seconds. And at the time of his aspiration, he'd had his blood transfusion by then, and he continued to have a prolonged PTT. So notably, there's obviously a change, a significant change from baseline, where he had normal coagulation parameters, and now his PTT is prolonged and abnormal. So what is your differential for an isolated prolonged PTT? So I like to separate my workup for this into two categories, a deficiency or an inhibitor. And remember, your PTT is affecting your intrinsic pathway. So when we're thinking about deficiencies, we're really thinking along the lines of factor 8, factor 9, factor 11 deficiencies, as well as sort of higher up in the cascade that's really involved in clotting within the test tube. So in vitro clotting, which includes your contact factors, high molecular weight kininogen, precalorin, and factor 12. And then the way I like to think about it when I'm working up a patient is look at the patient, and is the patient having bleeding symptoms or not? If they're having bleeding symptoms and there's a possibility of deficiency, you're really in the line of either factor 9, factor 8, or factor 11 deficiency. If they don't have bleeding symptoms, they can still have a very prolonged PTT, but this means that the deficiency is much higher up in the cascade that's not involved in vivo hemostasis. In other words, these contact factors are only required to initiate the PTT assay inside the test tube and not within the patient. Sorry, these slides are advancing on their own. Moving on to the inhibitor side of your differential, you can have inhibitors against specific clotting factors, so factor 8 and factor 9, as well as non-specific inhibitors that can be against reagents or parts of the PTT assay, so such as phospholipid antibodies or lupus anticoagulant is probably the most common that we know about. Again, I think about differentiating into antibodies as well as drugs that we know will inhibit clotting factors. So your most common drugs that's going to prolong your PTT is heparin and direct thrombin inhibitors. So that includes argatroban, dabigatran, and then not as significantly prolonging the PTT, but direct 10A inhibitors can also prolong the PTT. On the antibody side, again, I like to think about the patients who are bleeding and the patients who are not bleeding. Those who are bleeding will most likely have inhibitors against a clotting factor that neutralizes the clotting factor so it can't create hemostasis. Whereas those who don't bleed typically have an inhibitor or antibody to a reagent or substance that's needed to cause clotting in the test tube. So that's your lupus anticoagulant or non-specific phospholipid inhibitors. So moving on to what test should you order when you're working up a PTT? So an isolated prolonged PTT, your differential is inhibitor versus deficiency. And in order to determine that, your first step is to do a mixing study. And this is your screen for an inhibitor or factor deficiency. And the way a mixing study works is you take the patient's plasma and normal plasma and mix it 1-to-1, and you remeasure the PTT. So if your patient has antibodies or an inhibitor that neutralizes clotting factors, when you add back normal plasma, which contains 100% of all the clotting factors, the antibodies will still bind and neutralize those clotting factors. So when you measure the PTT in the mixed tube, it will still be abnormal and prolonged. Whereas if you have a deficiency, the patient is missing all their clotting factor. And when you add back normal plasma, which has lots of clotting factor in it, it will correct the PTT. There will be enough clotting factor there that the PTT will shorten and go back into the normal range. The second step, once you've determined whether there might be an inhibitor or not, is to figure out which factor is being affected. So you want to measure the factor activity levels. And because you're looking at the intrinsic pathway, the PTT pathway, you're looking at factor 9, 8, and 11. Now, you don't need to go on to order factor levels if your patient is not presenting with bleeding symptoms, or you already have determined they have a lupus inhibitor present. So going back to this patient's case, the patient sample had an abnormal PTT, which we know about, so 106 seconds. The control sample is normal, 25 seconds. And on the one-to-one mix, the mixing study, we can see it's still 101 seconds, so it does not correct. This is consistent with an inhibitor being present. And when you moved on to figure out what is this inhibitor against, your factor 8 level is low at 1%, meaning you've got a factor 8 inhibitor with a high Bethesda or inhibitor titer of 152 Bethesda units. So this is a case of acquired hemophilia A. This is a bleeding disorder that's caused by an autoantibody against factor 8. The incidence of hemophilia A, acquired hemophilia, is very low. It's very rare, and even hematologists at a tertiary care center may only see one or two of these in their practice, in their career. So the incidence is about 1.5 per million per year. It mainly affects older individuals, but can also be associated with other medical conditions such as autoimmune diseases, malignancy. It can be drug-induced, certain skin conditions such as pemphigus and pemphigoid, as well as a unique abnormality in the postpartum state. The bleeding in these patients can range from life and limb threatening to very mild bleeding. And patients should have no personal or family history of bleeding. So this is not a congenital hemophilia. This is something that they acquired, and it's an autoantibody. The mortality is quite high, anywhere from 8 to 22%, and is related to bleeding and complications of immunosuppressive therapy. Their bleeding phenotype is different from those with congenital hemophilia. We know hemophilia A and B patients who are severe present mainly with deep tissue, intra-articular joint bleeding. These patients tend to have more mucocutaneous, soft tissue, GI bleeding that can be life-threatening. This is some typical pictures of patients and the skin findings and the large ecchymoses we can see. And it can be with very minimal or no trauma. This is a significant hematoma following a venipuncture. You can see this was actually due to, the blood pressure cuff causing very, very extensive ecchymoses. And they can drop their hemoglobin with this degree of subcutaneous bleeding. So clinical pearl here, the diagnosis of acquired hemophilia, unfortunately, is still often delayed. And this is usually because they present to physicians who may not be specialists in the field or may have never seen or managed a case. And as I mentioned, it's rare. So you may never come across one of these cases, or only one or two in your life, in your career. Because of this delay, it can result in suboptimal treatment and significant bleeding complications. And the key ultimately is to order that mixing study to look for the inhibitor and make the diagnosis. So the big message I want to get across is that you should never let a PTT go unexplained. If you have good reason why that PTT is prolonged, for example, the patient is on low molecular heparin, or they are on dabigatran, or the sample was drawn from a central venous catheter where heparin was used to lock the lines, then yes, you've got an explanation. Or they have a lupus inhibitor and that's been documented in the past. No, you don't need to further investigate it. But if a patient is coming in, especially with bleeding symptoms or concerns for possible bleeding symptoms, dropping hemoglobin, and that PTT is prolonged and it's never been prolonged before, then we need to investigate it further to make sure you're not missing acquired hemophilia. How do these patients get treated? The treatment and management of acquired hemophilia is twofold. First is to treat and stop the active bleeding. The second is to get rid of the inhibitor. In order to treat the acute bleeding, there are three different ways we can go about doing this. One is to overwhelm the inhibitor. That's giving lots and lots and lots, very high doses of factor 8 concentrate to try and overwhelm it. And this only works when the titer is very low, so less than 5 Bethesda units. Otherwise, if it's a high titer inhibitor, we need bypassing agents to get around that factor 8 cofactor step in the clotting cascade. And that's done by using recombinant factor 7A or factor 8 bypass factor 8 inhibitor bypass activity, also known as activated prothrombin complex concentrate or APCC, to get around a factor 8 within the clotting cascade. The third way, and this is available at some of the more major centers, is to use a product that is not neutralized by the human factor 8 antibody. So this is recombinant porcine factor 8 concentrate, and there's very little cross-reactivity for porcine factor 8 with the human factor 8 inhibitor. To eradicate the inhibitor is very important in treating acquired hemophilia A, because as long as the inhibitor remains present, these patients will have a prolonged PTT and they will remain at high risk of serious bleeding. We use various immunosuppressive therapies, including steroids plus cyclophosphamide, rituximab, and other cytotoxic agents. So that brings me to the end of case 1. We'll open it up for questions and discussion. And I believe we do have one follow-up polling question for the audience. How many acquired hemophilia patients have you seen in your emergency department? Never seen one, 1, 2 to 5, 6 to 10, more than 10.
Thanks, Adrienne. We do have a couple of questions that came in through the chat. What's the turnaround time for a mixing study? Is that going to potentially be a limitation? And maybe just to follow up, are there some labs that are going to run a mixing study automatically when they run into a very high PTT that's not explained?
Yeah, so to answer the first question, I think the turnaround time is going to depend on where your center is. Most tertiary care centers can turn around a mixing study within 2 hours. Okay, if you're asking for stat and it's just the mixing study, so the screening test, usually within 2 hours we can get an answer. If you're at a more rural site, that's going to be a bit more difficult. You can call your local coagulation lab and tell them I want a mixing study. Most labs will be able to do that, even at more community or rural sites. It may not be able to tell you if it's a lupus inhibitor versus a factor 8 inhibitor, but it can tell you, okay, well, the PTT didn't correct. There's something wrong here. There's probably an inhibitor present. So generally within a few hours, if you're calling the lab and speaking with the technicians, they can get that information to you. Do we regularly work up prolonged PTTs at certain labs? No, most labs don't. You generally have to request a mixing study, and then locally, our lab is very good about taking the testing further. So if they see there's the mixing study does not correct and there's potentially an inhibitor, they'll go ahead and look for that lupus inhibitor and look for your factor 8 and factor 9 levels. So we do have some automated triggers here locally, and I think most tertiary care centers probably do. But at rural sites, it often requires a referral to one of the main laboratory centers.
We've got a great question in from Mike, and it's about patients who are receiving heparin. I mean, there are usually order sets or guidelines for this, but when is a PTT too high on heparin? When do you need to shut it off, I guess, or risk potential bleeding? I mean, older doctors have a lot more experience with unfractionated heparin because we've used it so routinely, but it is not in common use anymore with so many other anticoagulants around. So what would your thoughts be there?
Yeah, I mean, I think really the risk of bleeding depends on how high that PTT is and how long they remain at such a high PTT. So of course, if we see, and it really depends on the nomogram, there's different nomograms for DVT-PE versus cardiac or stroke protocols. So generally there are some guidelines as to when to slow the rate. Typically, if you're seeing a PTT of greater than 100 or 150 seconds, you need to stop. You need to hold that until it comes back down within one of the ranges defined in your nomogram. And I wouldn't leave someone with a PTT high, above 100 for more than 2 to 4 hours, that would put them at significant risk.
Meg has a great question about potential over-referral. So how long does the PTT have to be before you arrange a follow-up in the anticoagulation or hematology clinic to make it a reasonable referral?
Yeah, so what I usually say is any prolonged PTT is potentially abnormal. The PTT reagents that most labs use for clinical purposes are very sensitive, because what we want to do is be able to detect even very mild deficiencies, because mild deficient patients may not have day-to-day bleeding, but if you operate on them, they will bleed like stink. So we don't want to miss those patients, which is why our PTT reagent is very sensitive. Usually what I say is you should at least do a repeat PTT. If that PTT corrects into the normal range, then you can say, okay, well, that was maybe some pre-analytical error, and this patient doesn't actually have a bleeding disorder. Obviously, clinical symptoms are also important. So if you have someone with a slightly prolonged PTT, but also has bleeding symptoms like epistaxis or menorrhagia, I mean, that's enough to question that maybe they have a mild bleeding disorder and they should be referred to a hematologist or a bleeding specialist. Our center, at least, we say anything that's persistently prolonged, even if it's like 38 seconds or 39 seconds, just send them all our way. And oftentimes we'll do a bit more refined testing and decide whether or not we actually need to physically see the patient or not. The last thing you want to do is miss somebody with a bleeding disorder, especially if they're coming to see you prior to an operation or a surgery.
Thanks, Adrienne. We've got one more quick question before we move you on, because I know there's two other interesting cases that you've got for us. But is it possible that we're underestimating AH frequency because we're not doing as many PTTs, and these are not always recognized as bleeding disorders in the community?
Yeah, I mean, I will tell you that I think since we've done more of these talks and done more educational sessions with emergency care physicians and primary care physicians, I've actually seen way more acquired hemophilia in the last 2-3 years. And I suspect the incidence is actually much higher than 1.5 per million per year. And I think a lot of it just goes undiagnosed. Some of these patients can have acquired hemophilia and they don't have bleeding. So it's just the PTT that's prolonged. They might notice some more bruisability, and some of these will actually spontaneously remit on their own. So their inhibitor just disappears over the course of a year and they go undetected. So it's always good to make the diagnosis, because those patients can still relapse and develop bleeding. But I do suspect there is definitely an underdiagnosis component to this.
Awesome, Adrienne. I'm going to let you move on to the next case, because we do only have an hour for all this.
Okay. All right, let me go back to my slideshow here. Okay, thank you for that. All right, so we're moving on to case 2. This is more of a practical, situational case. So this is a 21-year-old female who comes to your emergency department with severe headache, neck stiffness, photophobia, and fever. And you're worried about meningitis and you would like to perform a lumbar puncture. She tells you she has von Willebrand's disease, but hasn't seen a hematologist in years, can't recall what type. She was told sometime in childhood she has von Willebrand's disease, never had an invasive procedure where she needed treatment with DDAVP, and doesn't even know what her response is to DDAVP. She does have a Factor First card or a treatment care card, but she forgot hers. So you go on and do some blood work. She has a normal hemoglobin and platelet count, a slightly elevated white count, normal INR, and a slightly elevated PTT of 39 seconds. Our normal range goes up to 38. So what do you do? Do you go ahead and do the LP because her PTT is only slightly prolonged? Do you give her a dose of DDAVP and then do the LP? Do you give her von Willebrand factor concentrate, then do the LP? Do you call hematology and ask them what to do? Or are you lucky enough that your center has access to specialized care plans for complex patients, and you'll check in there and see what the document tells you to do? I'll turn this over for the polling.
And we could maybe ask people if they're already registered for the chat to put in their thoughts on that question into the chat window. I think it's a call for help, call a friend moment.
Yeah, call a friend. Okay. So a bit of background on von Willebrand's disease before we get to the answers to that question. So VWD is the most common congenital bleeding disorder. It has a prevalence of anywhere from 1 in 100 to 1 in 1,000 persons. The bleeding symptoms can vary depending on severity and the type of von Willebrand's disease. Most bleeding symptoms are usually mucocutaneous, so epistaxis, gingival bleeding, GI bleeding, hematuria, and in women, uterine or menorrhagia. Bleeding can also occur with invasive procedures, so dental extractions, surgery, and childbirth. We classify von Willebrand disease, and this is taking you back to medical school, maybe, into sort of 3 main categories. One is type 1, which is a quantitative deficiency in von Willebrand factor. So both the antigen or the protein levels, as well as the activity, so the functional activity of the protein, are similarly decreased, and most type 1 patients will be responsive to DDAVP. Type 2 patients have a qualitative defect in VWF. The von Willebrand factor activity, so the functional component, is much lower than the actual protein or antigen levels. And there's various subtypes of type 2. Most of them will be responsive to DDAVP, but some of them may not be or may not have an adequate response to DDAVP. Type 3 is the complete absence of von Willebrand factor. Both the activity and antigen levels are essentially 0 because these patients make no von Willebrand factor, and this cannot be treated with DDAVP. So what are the target pre-procedural levels for invasive procedures? So this really depends on how invasive and to what extent the procedure is. So for major surgeries like orthopedic or intra-abdominal, we're targeting levels of 100% or higher pre-op. Minor procedures like dental extractions, usually somewhere around the 30 to 50% range. And more specifically, with lumbar puncture and neuraxial analgesia, we target levels of 50% or higher. The general rule of thumb, so this is a pearl for any bleeding disorder, is we want to replace with the factor concentrate for which the patient is deficient. So in von Willebrand's disease, they're missing von Willebrand factor. So what you want to do is you want to replace the von Willebrand factor. And there's 2 ways in VWD to do this. One is to increase your endogenous von Willebrand factor levels. And the second is to replace the deficient von Willebrand factor with clotting factor concentrate. So DDAVP will stimulate the release of von Willebrand factor multimers from your vascular endothelial cells, and this is an effective treatment for most type 1 and some type 2 VWD. We do recommend that DDAVP testing is done before treating von Willebrand disease patients to make sure they do have an adequate response. So coming up to 50% or higher in terms of their factor levels after they get DDAVP. DDAVP can be given intravenously, sub-Q, or intranasally. Clotting factor replacement is, there's different brands of it. There's Humate P and Willate, which are the most common. And it is the standard treatment for type 3 and some type 2 VWD. It's also used for those who don't have an adequate response or do not respond to DDAVP. And this is given as an IV slow push. So when in doubt, if a patient has VWD subtype that's unknown, if you can't confirm they've had DDAVP testing, or whenever you're in doubt, you just give the von Willebrand factor concentrate. And like I mentioned, that's because 15 to 20% of type 1s do not have a good response to DDAVP. In certain types of type 2 von Willebrand's disease, it can actually cause worsening thrombocytopenia. And of course, those with type 3 VWD will not respond to DDAVP at all. A few other clinical pearls when it comes to von Willebrand's disease. So DDAVP can cause symptomatic hyponatremia and seizures, especially in really young children or the elderly. And we usually recommend patients limit their fluid intake to 1.5 liters or less for about 24 hours after they get their DDAVP. You can develop tachyphylaxis with repeated DDAVP doses, especially when given in a short time frame. We often recommend the use of antifibrinolytic agents, so tranexamic acid with mild mucocutaneous bleeding, or as an adjunctive treatment when you're giving DDAVP or von Willebrand factor concentrate. DDAVP, as I mentioned, can be given sub-Q or IV. If it's going to be given IV, it's mixed in a 50 cc saline mini bag and infused over 30 minutes, and the usual dose is 0.3 micrograms per kilogram. It can also be given intranasally, but I caution you that you have to pay attention to the dose. So the dose is 150 micrograms per meter dose nasal spray, 2 sprays for adults, 1 spray for those less than 40 kilograms, so most children. But you should not confuse intranasal DDAVP dose with the nocturnal enuresis DDAVP dose, which is much lower, 10 micrograms per spray. And most hospital formularies carry this lower dose. How fast does DDAVP or factor concentrate work? Almost immediately, but generally we recommend it to be given 30 minutes before the invasive procedure to make sure you're at peak levels. So that's the end of case 2. I think we have one follow-up question just with regards to care plans. So does your ED develop specialized care plans for complex patients or patients with bleeding disorders?
Great. And are those usually patients with rare diseases? Is that the kind of generally driving force behind the care plans because they're not frequently encountered?
Yeah, I think that at least here locally, that's what we've done. Almost all our bleeding disorder patients will have a care plan that's available to the emergency physician through the EMR. And that's just to make sure that, there's no confusion as to what the patient should be receiving. There's also certain specific concentrates or product types that a patient is best treated with. Some patients have allergic reactions to certain products, and not all concentrates are always appropriate for every bleeding disorder patient.
Well, it looks like for the 15 who have responded, they're not yet doing care plans, but that's a really good insight. I'll let you move on, Adrian, to your final case.
So the last case, case 3. So this is a 23-year-old male who presents with left-sided abdominal and groin pain. And his pain started several hours after he was jumping on a trampoline with his friends. And he tells you he has severe hemophilia A and has a factor VIII inhibitor. He's on a new treatment drug called emicizumab. His vitals show that he's a bit tachycardic at 115. His blood pressure looks good. His SATs are okay. His temp is 37.7. He appears quite uncomfortable when you examine him. He's not able to stand up straight or lie completely flat on the exam bed due to pain. He's reporting some pins and needles with altered sensation to his anterolateral thigh. And there's guarding on abdominal palpation, no swelling, warmth, or bruising that you can see. His blood work shows his hemoglobin slightly low at 117, white cell count is 14.3, platelets are normal, lights and creatinine are normal. His PTT is 35 seconds, which is actually normal. So that's within the normal range. He does not have a prolonged PTT. INR is normal. So you are worried about an iliopsoas bleed. What investigations do you want to order? An X-ray of the abdomen, ultrasound, CT scan, or none? You treat him first.
And while we're waiting for those to come in, would most of these patients have a direct line to a hematologist to, if they're in trouble, or do they usually get the answering machine that says, go to Emerg?
Yeah, so our hemophilia patients, they do have a direct line to our clinic. Our clinic is open, working hours of the weekdays. So they'll always have access to one of our nurses within those hours. Our patients are also given our the paging system to ask for the hematologist on call. So they can get advice after hours or on weekends from a hematologist. So they do have a direct line to us. It's not always a bleeding disorders hematologist, but at least locally here, all the hematologists have our cell phone numbers. So generally one of us gets involved from the bleeding disorder clinic anyway.
All right. Well, we may be expecting a big wave of hemophilia patients moving to Calgary then for that kind of service. Looks like most people are kind of torn between, well, all three options are receiving answers. So I'll let you take it from there.
So the answer to this is D. Whenever there's a clinical suspicion of a severe or life-threatening bleed in a hemophilia patient, just always give him factor concentrate first and then send him for the investigations. And for an ileoceous bleed, you typically want to do a CT scan in order to visualize the extent of the bleeding. So why is his PTT normal? This must be a lab error. His PTT should be prolonged because he has severe hemophilia A. He said he's on treatment, so his normal PTT must mean he has normal hemostasis, so he doesn't need any extra treatment or factor concentrate for this bleed. He's on emicizumab, which interferes with the PTT assay, and the values look normal when factor VIII levels are actually still low. Or I have no idea, call hematology.
And Adrian, the icusizumab, that's monoclonal antibody type of
intervention? Yeah. So it's one, we'll get to that, but it is one of the more novel non-factor treatments for hemophilia.
Great. So obviously our audience has a lot of expertise in multiple choice questions. And yes, they're going with C.
Okay, good. That's the correct answer. Okay, so I will move back to my slides here. So this is our patient CT scan. You can see with the gray arrow, he's got a very large left ileoceous bleed there. So just a few basics on hemophilia. We all know this is an X-linked hereditary condition caused by the failure to produce clotting factor within the coagulation cascade that's needed to generate thrombin and to form a platelet fibrin clot. Males are affected while females are carriers, but it's important to remember that about 1/3 of female carriers will have bleeding symptoms and can have low factor levels due to lionization. There are two main types of hemophilia. So hemophilia A, previously known as classical hemophilia, is a deficiency in factor VIII. It affects 1 in 10,000 individuals. There's about 2,500 Canadians affected by hemophilia and represents about 80 to 85% of the hemophilia population. Hemophilia B is also known as Christmas disease. It's a deficiency in factor IX, affecting 1 in 50,000 individuals and approximately 600 Canadians. Severity is based on factor level. So severe is considered a factor VIII or IX level less than 1%, moderate between 1 and 5%, and mild greater than 5 up to 40%. And the severity of bleeding correlates with the degree of the factor deficiency. So treatment is pretty straightforward. In hemophilia, you replace the missing clotting factor. So hemophilia A, you're going to replace with factor VIII concentrate. Do note that for mild hemophilia A, some of them can be treated with DDAVP because that also increases endogenous factor VIII levels. Hemophilia B, you're going to replace with factor IX concentrate. On the market, and patients will be on either long-acting or standard half-life recombinant factor products, and either of these would be appropriate and can be used for acute bleeding events. The exceptions in terms of simply replacing with the missing clotting factor is when you have a hemophilia patient with an inhibitor. So 25 to 30% of severe hemophilia A patients will develop an inhibitor against factor VIII. And just like with our first case, if there's these neutralizing antibodies, it doesn't matter how much factor VIII concentrate replacement you give them, the antibody will neutralize it and prevent that factor concentrate from controlling bleeding in these patients. So the bleeding management is pretty similar to case 1. You want to get around the fact that you have inhibitors against factor VIII. So you need to get around that part of the coagulation cascade, and that's done by bypassing agents. So either recombinant factor 7A or activated prothrombin complex concentrate, or APCC. Or there are also novel therapies that just do not rely on factor VIII activity to achieve hemostasis. And one of these is emicizumab. So this is a bispecific humanized monoclonal antibody to factor IXA and factor X, and it basically mimics the cofactor activity of factor VIII in terms of its function. So normally activated factor VIII brings together factor IX and factor X, forms that 10-ase complex. And once you have this complex, it will convert prothrombin to thrombin and create a clot. Emicizumab just takes on the role of factor VIIIa, bringing together factor IX and factor X, making that complex to convert prothrombin to thrombin. Now, emicizumab is effective for prophylaxis, so the prevention of bleeding in hemophilia A patients with or without inhibitors. It has recently been made available in Canada for hemophilia A patients with inhibitors, and also just been approved by CADTH for hemophilia A patients without inhibitors. There's some important differences between factor VIII concentrates and emicizumab. Factor VIII concentrates are effective for both the prevention of bleeding, so prophylaxis, and treatment of acute bleeding, whereas emicizumab is good for preventing bleeding, but it takes too long for its action to, the onset of action is too long with emicizumab, so it cannot be used for treatment of acute bleeding. In patients who are still on emicizumab and have bleeding symptoms, they actually need to receive either factor VIII concentrate or bypass agent to stop acute bleeding. Factor VIII concentrates are given intravenously. They have a short half-life, so most patients have to dose it every 2 to 3 days if they have severe hemophilia, whereas emicizumab has the benefit of a sub-Q administration, a long half-life, and is dosed every 2 to 4 weeks. The other thing is factor VIII concentrates. We know we can measure a factor VIII activity level. So I give a certain dose of factor concentrate, I can measure how high the factor VIII level comes up. And it doesn't interfere with my PTT assay, doesn't require any special assays or reagents. Whereas emicizumab, you cannot measure the factor VIII activity levels. There's no correlation of the drug effect and the actual factor VIII activity. And this drug will interfere with your PTT assay. It will make your PTT look normal because it's causing clotting within the PTT test tube with our typical reagents, but the factor VIII activity level is actually still 0 within the test tube. So it requires specialized agents and assays in order to monitor treatment in individuals on this drug. So having a clear care plan developed with input from hematology becomes an important safety feature in managing these complex patients with rare bleeding disorders, especially when they're on new unfamiliar therapy. Most hemophilia patients will have a Factor First card with their specific treatment protocol. And this is what the Factor First card looks like. There's some general recommendations on what doses to give for life-threatening bleeding and what qualifies of life-threatening or major bleeding. They will have the Hemophilia Treatment Center information and contact number on the card, as well as the patient-specific product recommendations. But if it's missing, in Calgary, we are lucky that all patients who are part of the Rare Blood and Bleeding Disorders Clinic will have an ED treatment protocol, and that can be found in our clinical information system in SCM. Other resources to go to are the Hemophilia Society. They have emergency care sort of treatment recommendations, as well as the World Federation of Hemophilia has treatment guidelines. And a great resource, this is actually a YouTube video developed by our colleagues at St. Mike's Hospital, specifically for emergency management of hemophilia. And I think that's the end. Yes. I'll hand it back over to Dr. Lang. Thank you.
Thanks so much, Adrienne. That was awesome. Couple of questions coming in and just some additional things. So I don't think I've met a patient on emicizumab. Are they considered immunosuppressed? And are there any other complications that we need to watch out for in hemophiliacs who are on chronic treatment?
Yeah, they're not considered immunosuppressed. It specifically targets the factor IX and factor X clotting factors. So there's really no effect on humoral immunity or T cell function. It doesn't affect the other antibody production from your B cells and your plasma cells. So they're not immunosuppressed. There are some other side effects associated with the drug, mainly headaches, some sinusitis, and infusion reactions and site-specific sort of reactions. We currently only have one patient on this, and I believe there's maybe one patient at the Children's that's on this medication, because currently it's only available for inhibitor patients, but it is coming. Canadian Blood Services is looking at contract negotiations with the industry partner that supplies this drug. And now that CADTH has approved it for all hemophilia A patients, invariably, we're going to encounter hemophilia patients on this drug.
And a question from guest, can you use bypassing agents if they're presenting with the acute bleed?
Yes, so in a patient with an inhibitor on emicizumab, with an acute bleed, you can still treat with bypassing agent. There is some caution with factor VIII inhibitor bypass agent, or APCC, as there have been thrombotic microangiopathies, thrombotic events that have occurred with giving too much of the APCC in someone on emicizumab. So we typically recommend, if you're treating, well, call us, but also usually we use factor 7A, activated factor 7A, to stop the bleeding.
That's awesome. And something that often comes up when we encounter a patient while we're trying to figure out what to give them, either by calling hematology or transfusion medicine on call, where does TXA fit? Is there any value to, I don't know, Emerg docs love TXA. We use it in epistaxis. We use it in menstrual bleeding. Where does it have any value in a really bad bleed that you suspect is either from an acquired or congenital coagulopathy?
Right, yes. So we also love TXA. We love tranexamic acid. It's really, really good for mucosal type bleeding. So we do use it often, and we use it in conjunction with clotting factor concentrate with severe bleeding. So even sometimes with joint bleeds, but definitely with muscle or soft tissue bleeds, GI bleeding, epistaxis, menorrhagia, gum bleeding. The only place I caution tranexamic acid is if the patient is having hematuria. If you don't know if it's coming from a urethral site, urethral sites are probably safe, but if it's coming up from a glomerular site and you can't confirm that, you can cause obstructive nephropathy with clots forming in the ureters with TXA. So that's the only time where I don't use it. But yeah, we use it almost all the time, even for surgeries and post-op situations.
That is super helpful. Well, I think we have pretty much gone through the questions, and we're really up to the end of the time. Just recall that we would love to have your feedback on this, and if you need any additional information, I'm sure I or Dr. Lee would be very happy to provide it. So I want to thank everyone who joined us today. Big thank you to Dr. Lee for this really valuable talk, our scientific planning committee for their input, and of course the CAPE staff for their input. This again has been accredited by both the College of Family Physicians of Canada and the Royal College, so you're of course able to retrieve your credits for attending, and that will be mailed out to you if you've already registered for this event, and that will be following up. So just to recall that pandemic times means different approaches to medical education, and CAPE has pivoted and met the challenge by coming up with a whole series of interesting live lineup on-demand educational webinars over the next few months. So keep your eye out in CAPE Connect or on Twitter, and you should be able to sign up for more of these if you found them interesting. Want to thank again everybody for making the time this morning, if you're in the West, afternoon if you're in the East, and we'll wish you a fantastic rest of the day, and wishing you also lots of health and safety as we hopefully turn the corner on COVID-19. Thank you very much.